Welcome to our first SSHM webinar. My name is Rosemary Cresswell and I'm the chair of the Society for the Social History of Medicine. And today we're going to be considering debates and questions around coronavirus, examining historical precedents to consider the coming months and potentially years. So today I'm joined by Flurin Condrau, if you could give us a wave.
Hello.
Flurin's the professor at the Institute of Biomedical Ethics and History of Medicine at the University of Zurich, and his publications include ones in infectious disease and research on pharmaceuticals. So it's great that you can join us today, Flurin. We've got Michael Bresalier.
Hello.
Hello. Lecturer in the History of Medicine at the University of Swansea, and his publications include ones on human and animal health and influenza plus vaccines as well. So obviously a great person to have on board today. We've got Samiksha Sehrawat. Hello. Samiksha is Senior Lecturer in South Asian History at the University of Newcastle, and her publications include ones on colonial medical care in North India, that's a book published by Oxford University Press, and much more on issues like women's history and military history. And we have Pratik Chakrabarti.
Hello.
He's Professor of History of Science and Medicine at the Centre for the History of Science, Technology and Medicine at the University of Manchester. He's the author of a broad range of publications with relevance for today, including 2 books, Medicine and Empire 1600 to 1960 and Bacteriology in British India. He's also got articles on topics like cholera and vaccine research, which are also very appropriate. And one of the reasons we've got these 4 people with us today is because of their connections with SSHM. So Pratik was one of our editors for many years. Flurin is one of our new editors and is a past chair. Michael was going to be organising our anniversary conference in Swansea this year, but he will be organising next year still, and we'll be in Swansea, and we'll hopefully be considering some of the reflections on coronavirus at that conference too. And Samiksha is our current conference coordinator, so she's been involved with that too. Firstly, we've obviously been emerging from the lockdown in Britain over the summer. And I wondered what do you think we can consider from previous attempts at quarantine in pandemics in Britain and internationally as being relevant for this experience?
That's a challenging question. I mean, in a way, I'm hesitant to say that we can draw significant historical parallels, in part because the kind of quarantine measures, if you want to call them that, the forms of social isolation, the lockdown that we've experienced both in Britain and across the world is really unprecedented. I don't think there are really any other historical examples, just in terms of longevity. We can see parallels, for instance, I mean, the one I'm most familiar with in some ways is what happened in 1918, which is, you see a broad range of relatively uncoordinated and mostly local efforts to develop modes of, social isolation, social distancing, the terms that we would now use, in order to slow the spread of the 1918 pandemic. But by and large, with the exception perhaps of Australia, which attempted a more systematic approach to quarantine, these were local and they were relatively short term. School closures, cinema closures, other types of restrictions that lasted weeks, not months. And we might be looking at something that could stretch into months and maybe even longer. So I think in terms of coming out of in terms of the lockdown and coming out of the lockdown, in terms of your question, I don't know if we can sort of look to the past for many examples. I think we're venturing into sort of an area that's unknown in terms of the experience that we're going to have with this. But that's my view. There are some parallels, but there's not. This is in many ways unprecedented, and I think it suggests in some ways that each epidemic or each pandemic has its own sort of characteristics, its own logics, and its own responses. And we have to be a little bit cautious in looking for direct parallels with the past. That's not to sort of say we can't historicize, but I think that's an important qualification. But I'll hand over to my other colleagues.
I think it's an interesting phenomenon. I'll separate lockdown from quarantine, because lockdown is a form of quarantine in this case. But if you take quarantine as a whole, the historical parallels are easy to see, in the sense that there are two, three important facts about quarantine which has kind of remained constant from the past to the present. One is quarantine has always been a very political issue rather than just a medical issue. Quarantine has also been a very economically driven issue. What are the economic costs of quarantine? That we are saying here. Also, quarantine has been always defined in national grounds. Each nation have adopted historically, whether it's cholera, plague, or even typhoid in the US, have very local national policies. And it has always been very, very difficult to come to international cooperation about quarantine means. All of these kind of issues we are seeing here, that almost every nation has adopted its own mode of quarantine.
Yeah.
And you can almost draw historical parallels. It was almost predictable that Britain would bring in quarantine the last, because historically Britain has been, in the terms of free trade, been a very anti-quarantine as a nation. So it's almost, you could predict that Britain brought in quarantine about international travelers last, and and Britain had always resisted quarantine for cholera for a long, long time, while other nations had much stronger quarantine policies. And quarantine of groups which would affect mercantile products of coming in, goods, those were historically always concerns. Here we see the concerns about economy, how economies comes to a standstill. So quarantine and economy do not go together. So all those debates that we see about quarantine as political questions, about economic questions, and as very national politics, are the parallels that we see in most cases, including the current one.
I think in that sense, this question, I'm also very grateful for Pratik to put together the question of economics and the impact of the pandemic. And I think I'm not the first person to say this, but they have been very unhelpfully seen as different. So I think that there is this perception that the pandemic, controlling the pandemic is different from controlling the economic impact of the pandemic. And I think the question of lockdown and quarantining, as Pratik has mentioned, it's been something that's historically, this has been true, that if you try to, and I think what we fail to understand is that the pandemic will cause an economic impact, irrespective of the imposition of a lockdown or not a lockdown. So actually controlling the pandemic is controlling the economic impact of the pandemic. So the lockdown in that sense is not actually something that, the harm done to the economy is worse than the harm done to, done by the illness. I don't think we can actually think of that, especially in this increasingly global age. And so in that sense, if we look at the example of places like India and historicize that, the kind of, so in wealthy nations like Britain, in Europe, in America, which has failed to do the kind of things that the European countries have managed to do, you have certain kind of medical infrastructure, and the argument in Britain was that, we'll protect the NHS. So the lockdown is not just to save lives, it's to protect the NHS and to prevent the kind of situation that happened in places like Italy. In India, that's not the argument for the lockdown. And so the question was, what did the lockdown achieve? And in some senses, the way the lockdown was imposed was also very problematic, because it was imposed very draconianly, without any preparation, without any thought given to how it would affect some of the poorest people in the country, some of the most economically insecure people in the country, and that made it into international news as well. Something was done belatedly about it, but again, I don't know to what extent this has been thought through. So I think in some senses, this is a very novel situation, as in that this kind of a lockdown has never been attempted to try and control a developing epidemic. So we will learn much from what has been done or not been done, or what the impact of what has been done will be. But I think one of the things that makes places like India and other countries which don't have those kinds of medical infrastructure, they don't have the same level of hospital bed availability per population, they don't have the same kind of public health facilities per population. So just in terms of medical personnel, just in terms of dispensaries and primary healthcare units across the country. So I think in places like this, what lockdown means is something that it's very unprecedented from what we had before. And I think that's where also, I think historicizing it makes sense, because historically, it is one of the legacies of colonialism that places like India, countries in Africa don't have this kind of infrastructure. And the fact that post-colonial nations have not prioritized healthcare is now showing up in both the impact in terms of human lives lost, but also in terms of the economic impact of it. So neglecting healthcare has not been very good for countries like India that would like to claim that, you know, they are now moving into this big economic role on the global stage. So I'll pause there.
Right, then I can probably go last, adding my little bit of insight into this. I'm particularly interested in the historicity of the lockdown itself and the terminology used to describe it. I think it's largely misleading to talk of lockdown being the general international mode of response to the pandemic, because the lockdown itself means very different things in different populations. I remember reading the first reports coming out of China in end of January that Wuhan had been placed on the lockdown, and I thought this is the biggest quarantine experiment ever to be organized in human history. And by that, I think consequentially, I think it is important to look at the role of China. I think the role of China in the experience of lockdowns all across the globe is of paramount importance, because more or less we are being benchmarked against the Chinese experience. The Chinese numbers of cases has gone down ever since the lockdown was installed, and it has been kept down. And in many ways, the Chinese public health model is a success story in the way it controls Corona. How have we done? Our lockdown has probably been lifted a little early, at least in Switzerland. We see rising case numbers in quite dramatic fashion, and it's very doubtful as we go into autumn. But I maintain this, that we're in sort of a viral nationalism period, where all the nations around the globe find their own ways of filling the word of lockdown with meaning. What does it actually mean on a local level? And here, as historians, we have something to say. We have something to say about historicity and meaning that as something about context, place, and time. And I think it's really important to maintain this, that as historians, we speak about time and place. And the lockdowns in Europe mean different things from lockdowns in India, and the lockdown in India means something else compared to the lockdown in China. And I would like to pay close attention to these details.
I think that I mean, what Flurin's underscoring here is the point that Pratik made, which is that quarantines or lockdowns are themselves highly politicized. They're ideological, embedded with a sort of, you know, specific ideological meanings and connotations. And I take the point that there is significant variation between the meanings of lockdown. We need to pay attention to that variation. I mean, I think one thing that's and it raises an interesting point that, you know, this goes back to what you're saying about China, Flurin. It goes back to, you know, Ackerneck's sort of famous model around, you know, the contagionist versus the anti-contagionist views on quarantine. And I mean, if we look to China, we're also looking to an authoritarian response that might not be something that's easily translated into more liberal democracies. And, you know, that's one sort of, you know, historical contingency that we need to keep in mind. I mean, I think another is on the economic side. Until this pandemic, I think by and large, in terms of cost-benefit analyses, states, whether they be European, North American, or anywhere else, have tended to favor, you know, freeing up the market at the expense of public health. I mean, happens in the 19th century with cholera. It happens in the 20th century with the influenza, whether it be the 1918, the 1957, the 1968 pandemics. There's a very light touch in terms of the kinds of measures that we're seeing with COVID in those pandemics. And the cost benefit analysis is how many deaths are acceptable, how much morbidity, how much infection is acceptable. I think in terms of the cost benefit analysis, until this pandemic, the evaluation has been in favor of economics over public health, by and large. And this is quite interesting in this case, that there has been a prioritization in some instances of public health over the economic. The cost of this is going to be massive.
I mean, I'm really interested in your contributions throughout, because I know you've been thinking about the 1957 pandemic, and we discussed that right at the beginning, didn't we? Back in March, I think, that there obviously are precedents. So, and also that term of this being unprecedented, I noticed it came up in quite a few of your responses, and it's something that I always kind of, well, it's a word that's used continually, isn't it, in the media and by the public. And I wondered actually about your responses to that and your use of that in your replies.
No, I think one of the points that Michael raised is very, very critical, is the question of authoritarianism and liberal democracy. And I think we see this spectrum. If for the very sake of simplicity, if I put it that authoritarian states have adopted quarantine in a much more successful way than liberal democracies, which have many more complex layers of political, social spaces to consider. And China is a good example of that, and maybe Sweden is the other example. They're two different models. This is for the sake of simplicity, and for the sake of an important observation is what is interesting in this current phenomenon, and that does play an interesting role in our history of medicine debates about governmentality, is what is noticeable is when before Britain actually brought in its lockdown, there was a lot of demand from the public for the lockdown. So although it might be that liberal democracies are not pro-lockdown and authoritarian states are more easily bringing lockdown, but in terms of governmentally, what is it that now people demand more drastic lockdowns for schools, public life, social life, so a strong state. So there is actually in a liberal democratic situation, a demand for a strong state takeover and an effective state mechanism that actually does a counter kind of lockdown. So it plays tricks with our presumptions about lockdown and liberty in a simple way.
Yes, I think I completely agree with Pratik about and Michael in responding to the very interesting proposition that Flurin mentioned about these kinds of comparisons and the efficacy of lockdowns. And I think, again, I agree with Pratik that India and China can be contrasted, but I think one of the things that we've not quite articulated here is the responses in places like South Korea, which weren't necessarily as illiberal as China's, but were actually also very effective. And I think that's the other factor, which of course, I'm not the first person to say, the experience of having dealt with this kind of fast developing epidemic in the past, and having then learned the lessons and put the infrastructure in place, and the public knowing, so that there being an understanding. So public health having been redefined by the experience of a similar situation, and the lessons that the public learned as well has changed. So I think increasingly people are realizing that masks are a good thing. It's a public health thing. And we're expecting behavior to change post-pandemic for people's attitudes in the West towards masks, which has already happened in places like Southeast Asia and in China. So I think Pratik is absolutely right. It's an issue of governance. It's a response to wanting a strong state, and the form that strong state takes is also important to define. So it's not just a state that just comes in and imposes the most draconian lockdown. It is also about actually providing the kind of infrastructure that allows people to flourish. So this is also, I think, and here again, the economics and the public health overlaps. And so in some senses, the situation that we're in, the historical parallel would be the 1929 Great Depression. So it's wanting the state to play a bigger role in terms of containing threats that individuals cannot contain for themselves. So this is more of, in my view, a demand for things that we've called collectivism. So more of investment in public health and in the public infrastructure that would enable people to flourish. So one of the things that's been very positively received is attempts at providing some version of a basic universal income. And so the debates about that publicly are changing as well. So in some senses, this is not just a demand for the pandemic to be to be controlled. Of course, that's what it is, but it's also for the state to be doing what we know the state can do better than individuals or businesses or individual corporate organizations or non-governmental organizations can do.
So thank you very much for your responses. We'll move on to the next theme now. How do you think people and societies in the past learned to live with pandemics? And to what extent do you think they could try to live well during those periods?
This question came out of some conversations I had with a colleague back in Canada at York University, with whom I worked many years ago on social responses, social aspects of the AIDS pandemic, which, paradoxically we're still in the midst of. And out of that conversation came this question and this recognition that out of AIDS, there's a redefinition on the part of AIDS activists and people living with AIDS that one has to learn to live with the pandemic. So the idea of living with AIDS, people living with AIDS, I think that it posed for me a very interesting empirical and historical question about how people in the past and past societies have learned to and continue to live with epidemics, pandemics, and how they ripple through societies. And again, I mean, we can sort of default, there's considerable variation in historical contingency to this. With AIDS, I think what's quite remarkable, it's a very different type of disease insofar as how it develops. It's quite slow moving. So, it's not an acute epidemic disease in the way that we see with COVID. So there, in a way, there's time to develop a response, but there's been a remarkable transformation, I think, in terms in looking at AIDS, with the ways in which it sort of a moment of, in the 1980s, where there's considerable stigma attached to the disease, so the cultural aspect. There's a lack of, by and large, concerted governmental responses, and those responses are prompted by various types of grassroots activism. And we see through the 80s and 90s, a combination of grassroots activist responses, state responses, and movements towards issues around access to essential medicines, issues of equality and dealing with fundamental inequalities in access to essential medicines as the pandemic becomes something that is potentially more manageable. I mean, this gets back to the point that Samiksha was raising about healthcare infrastructures and healthcare inequalities. So the question of learning to live well with an epidemic disease, AIDS presents some very interesting, I think, lessons for the ways in which, I mean, there's lots of problematic issues around that pandemic, of course, in terms of stigma and blame, but also the ways in which at local levels, but also at international levels, there's mobilization to try and address fundamental structural inequalities in access to health care, particularly healthcare resources. And different models of providing essential medicines, whether they be treatments and maybe in the future vaccines, but also for just basic care that provides a sort of a picture or some insights into how internationally we've come to learn to live in a way with AIDS. For me, it's a question that we as historians need to think about. And COVID actually, I think, forces us to think about, well, not just about this as a crisis, but how people learn to live with the lasting effects of an epidemic. I mean, if you think of plague lasts for about 400 years in Europe. Cholera epidemics run through the 19th century into the 20th century. And so society, in European and internationally, societies and people have been living with pandemics continuously. What can we learn from those experiences? I don't have a direct answer, but I think it's an empirical question that we need to start to engage with in light of COVID.
Thank you very much for provoking that debate. And obviously it depends on where people are living for all of these debates. And that's why we've got people with expertise in India today. But I mean, thinking about the UK in comparison to, say, East Africa, then there are huge differences in coping with the AIDS pandemic.
I want to take up something that Michael was saying in referring to past pandemics. I think the first thing before we can start thinking about learning is to understand the forgetting that has been going on. We have forgotten the importance of pandemics. I've been teaching public health, its history and pandemic control and what have you for the last 30 years. And for the last 29 and a half years, the response from my students was nearly always the same. Oh yes, the good old days of public health. Those were the days in the 19th century when the big diseases were still of paramount importance in Western countries. Thank God we live today and we have no such problems. It's a bit similar to teaching feminism to adolescent girls. They say, oh, we have equality, we have gender equality in law, until they find at the workplace that actually life is a bit more complicated and maybe gender equality hasn't been achieved. And in a similar way, I think we need to engage this. Why has history been pushed to the side, history of public health been pushed to the side? Why is the narrative of medicine always so focused on the big innovative therapeutic successes rather than on the management of diseases? And you don't even need pandemics. Let's talk about rheumatism. Rheumatism is a case where medical management is of paramount importance over and above innovation. And in many ways, what we are now challenging is we're challenging the model of medical progress. And I think that's an essential first step to begin to start talking about the values of pandemic experiences and possibilities of learning to live with the pandemics, that we challenge the historical narrative that has been told for generations that medicine is always achieving for the highest possible therapeutic success and what have you. And I think once we appreciate that we have forgotten something, we can then start looking back to see how the past offers lessons and maybe doesn't at some point offer lessons of how to deal with it from a contemporary point. And one such lesson, just one, is that there has always been a tension in public health between local delivery and national decision-making. There's always been this tension. So it's totally unsurprising that at least in the countries that I'm vaguely familiar with in let's say in Western Europe, this tension has resurfaced. And it's clear that in the UK and in Switzerland and in France, the local experience of quarantine has been very unequal within the same country, whilst the nation state has attempted a coherent, maybe not achieved, but attempted a coherent answer to the pandemic. So only this tension between the local and the national, let alone the global, is something that we can start studying from a historical point of view. And it starts to make sense, at least where I am now in Switzerland. The learning process of the nation state was long. It lasted for almost 200 years until the nation state in Switzerland gave itself the powers for national measures in pandemic control. Only from 2012 had Switzerland as a nation found the legal powers for pandemic control. At the time, it was seen as totally peripheral because nobody in the political world expected a pandemic to occur soon thereafter. But still, it's interesting to see how long a nation state needs to learn until it actually develops some elementary steps of pandemic control.
Absolutely, and we've obviously had the warnings in the 21st century from diseases like SARS and avian flu and swine flu as well. Yeah, there's obviously no excuse for that.
Yes, it's an interesting topic, and I was thinking of how to separate the various debates. Now, for just my sake of understanding, I'll separate two things. One is living with a pandemic or an epidemic. The other is living with quarantine. And they are two separate experiences, although there are parallels between the two. And as far as COVID-19 is concerned, we are just at the beginning of learning how to live with the pandemic. We have been living with the lockdown, not actually the pandemic itself. And that's a very different experience. In terms of experience, which Michael was talking about, it's a different experience from living with a lockdown. And as far as living with the pandemic is concerned, there are obvious everyday lifestyle changes that we are already making. And we see why certain parts of Asia had already adopted wearing of masks as an almost everyday part of their dealing with life. You know, it's so that might become a regular part of living with COVID-19, the kind of cleanliness habits that we are relearning, sadly. The wearing of masks, the various kinds of measures that we are adopting is the beginning of probably living with COVID-19. And if we historically go back with that living of with pandemics, And AIDS is a fascinating experience, and there's so much for those who want to use it in classrooms, so much audio books about people in South Africa who are living with AIDS, and they've recorded those audios and they make a very important classroom and other discussions. So apart from that, you have historic cases of living with malaria in Africa, and how certain populations had learned to avoid malarial landscapes and lived in other parts of malaria, which was destroyed. That kind of living patterns were destroyed by colonialism, which changed the landscape, the agricultural landscape, and expanded the malarial landscapes in a way that they couldn't be avoided. So there have been historical ways of, depending on the kind of disease, some diseases are more ecological than others. So depending on the kind of, there's a whole reservoir of knowledge about living with epidemics, because it's as Flurin was saying, in the Western world, we are kind of privileged that we do not live with pandemics, and we have kind of almost forgotten the idea of living with pandemics. But in various other parts of the world, people are right now and have lived with cholera, with malaria, with AIDS all the time. So it's kind of reconnects us with those experiences, and it brings about the debate about what kind of sanitary movements or sanitation changes, personal habit changes that is required in living with COVID-19, because COVID-19 is here to stay.
Yeah, so I think, again, picking up some of the things that all three other speakers have mentioned, and you mentioned as well, Rosie. So I think the historical understanding of living with pandemics, I think for me, and it's interesting to see the different epidemics or different diseases that we think of as specialists, depending on what we focus on. So for me, I think the 1918-19 influenza pandemic is the closest parallel because it was global. It was also very similar to the COVID-19. So it was transmitted, it was a respiratory, transmitted through breathing, and it spread, it was airborne, and it spread in similar way. And because there was no similar kind of lockdown or quarantine, it happened very quickly. And then it got over. So there was enormous amount of loss of life. And of course, the economic impact was quite severe, but it got over very quickly because people didn't really, they couldn't understand it in real time. They couldn't control it in real time. And so in many senses, I think one of the prognostications that people are making is that we will have to live with COVID-19. It's now spread enough that it cannot be contained in the way that we hope to do in the early stages of the pandemic. So I think in terms of, we could separate the living with a pandemic as an individual experience and as what we could do to live with it as a society. And then when we think of society, it is the public, what we collectively now redefine public health as being, or as Pratik was saying, what hygiene now means, public hygiene means, and what people accept hygiene to mean and how it has changed. But also in terms of what we expect the state to do now. So I hope that discussions about this, public discussions about this, that there would be more public acceptance of the fact that the state should be providing a minimum amount of healthcare, and that should be something that rises to a political demand rather than just being something that's salutary that may be achieved sometime in the distant future, especially for countries which are considered to be developing or underdeveloped. So I think that should, and the arguments for this have been made since the 1990s by Amartya Sen and by people who are championing Millennium Development Goals. But also, if we think about it, going back to attempts to try and get primary healthcare through the UN much earlier than that, to ideas of universal healthcare, which might have originated in the West, but which were at one point considered as things that newly independent countries which had been colonized might adopt as goals for themselves as well. And they have receded from the political horizon. So I hope that sort of neglecting of healthcare as an important infrastructure that should be provided to all all citizens everywhere around the world. I think that's important. Another thing that's frustrated me is that people in the West think that if they have universal healthcare, that's good enough. So seeing healthcare as a national thing, but now we're realizing that if there is not national healthcare for people in Africa or people in South Asia, that's in a globalized world that doesn't insulate people in the West from the things that can happen elsewhere. So I hope that there will be an international understanding of these diseases. And that also links me with some of the things that both, I think, Pratik and Michael were talking about in terms of ecology. I think the other thing I hope will shift is that we will stop, and maybe Michael can speak to this. I think we should stop thinking of healthcare as something that we can do for human beings. And if we just mistreat animals, that doesn't have any effect on us. We know we've been reading news stories throughout about how this is not true. And again, I think Michael can speak to it better, but I hope that that's something that will change, that we will stop thinking of ecology as somehow not linked with healthcare. So in terms of social responses, in terms of governmental responses, in terms of international responses, I hope that there will be a better understanding that these are not luxuries that we may afford down the lane, but if we want a global economy, then without these things, these things, pandemics can disrupt. This COVID-19 is not such an exceptional thing to happen. This could happen very easily again. And the entire economic disruption, all of this could happen again. So in terms of our public thinking of it, we need to redefine our political debates about health, our thinking about health. And I think to a certain extent, the shift has taken place, but it hasn't taken place evenly. And again, probably Pratik can speak more to it, but attitudes towards science are playing a very important role to it. So of course, America is in the international spotlight, and everybody is amazed at why America is failing to do things that governments and the public in Europe are managing to do quite easily. And there's the worry that there will be an anti-vaccination response there, which may mean that we may have to live with things like COVID-19 for a much longer period of time than we would like to. So with the rise of right-wing thinking, which brings in religious fundamentalism into political debate, some of these relationships with science is changing in ways that may actually make us more susceptible to the continuing impact of pandemics than we would like to be. So the old days of having to live with such infectious diseases may not be that far away.
We were going to think a little bit about second and third waves of pandemics in a future seminar, but whilst I have you four together, I would be really interested in what you think about those waves. And obviously we've kept alluding to the 1919 flu pandemic, and it's that second wave that most people are familiar with. So where do you think we are with coronavirus? And what do you think we could learn from that and other pandemics?
Whether we call it lockdown or social distancing or quarantine, the kind of measures that are being put in place with COVID were by and large, I mean, I've alluded to this previously, were by and large not in place in 1918. I mean, in Britain and its empire, there was a mentality of carrying on in the context of the pandemic. And what that did is as Samiksha referred to this already, it let the pandemic sort of run its course. And so we see with an early spring wave, which is relatively mild, and there's all sorts of explanations for why the so-called second wave became so virulent and in many ways so deadly. But certainly one factor was the lack of mitigation strategies that were put in place. So if we're going to have a second wave of COVID-19, it may not follow the pattern that we see in 1918. It comes down to this concept, this term, which I think really deserves a lot more attention from historians, some really good conceptual analysis, and that's the concept of herd immunity. Letting a pandemic run its course, as most governments did in 1918, means that the herd gets exposed, and in some way experiences, and some in a certain number of cases dies from the disease. We have, in most governments, by putting in different types of social distancing measures, have ensured that herd immunity is something that is sort of delayed. I mean, it is, whether or not you sort of think of the vaccines as a kind of panacea, every government, every public health authority, I think expert, is looking towards herd immunity as one way of moving out of lockdown and into something different. What that looks like, who knows? But in 1918, the second wave was just basically allowed to develop. That second wave came, it caused widespread, just because the virus was spread very widely, and there's high levels of morbidity, and sort of in percentage-wise, relatively low levels of mortality, but enough of the world was infected so that have huge numbers of people dying. The death rate was relatively low, but the morbidity rate was really high. I don't know if we're going to have a second wave of the prediction is that we're going to. What it's going to look like, given the measures that are in place. I don't know if we can sort of draw strict parallels with 1918. I don't know what other parallels there are to draw, but I guess my default is this is a venture into the unknown. But the concept of herd immunity is something that I think we really need to sort of do a lot of work on, and to look at how the ways in which that sort of concept developed out of veterinary and animal medicine into human medicine, and has become a way of thinking about this problem of waves, the number of susceptibles versus the number of exposed.
Yeah, I think So I'll just continue with some of the things that Michael's already been saying about 1918 and the parallels with it. And again, I mean, I tend to look at India, I tend to look at Britain, and that's where my focus is. And in India, where I do not think that it will be possible for the government to have another lockdown, we will be closer to the situation, and not just in India, I think in other developing countries as well. We will be closer to the situation that we had in 1918, in the sense of not being able to impose quarantines that could prevent it. But it is also significantly different. So it is unprecedented in the sense that our biomedical knowledge and just our public health infrastructure is much better than what it used to be. So our understanding of the disease is much better, and epidemiology is far more improved. So we have all the past experiences to draw on in the sense that it has changed the way we think about disease, and it's spread through a population. But I think in terms of having had the experience of the first wave, it will have changed the behavior of individuals significantly, which will mean that the spread will not be as acute as it was. We're no longer living, I don't think anywhere in the world are we living in the way that we were living before the pandemic. And again, I say this, and I have to acknowledge my class privilege. There are people who cannot reduce their exposure to the virus, despite knowing what the impact of the virus will be and having perhaps experienced it already. So remembering that is also important, that there will be such people in larger numbers in some societies than in others, but in all societies there are people who are similarly situated. And so again, the point that Pratik made earlier in our conversation about who is expendable. It's not surprising that Black and minority ethnic groups have suffered the largest, both the morbidity as well as the mortality burden in the pandemic in places like the US and in places like Britain. And I wonder if we were to look at similar figures in places like India, we would probably see similar patterns, but perhaps in terms of caste, differentiation across caste lines and so on, so ethnic groups. So I think what the second wave will look like at the level of the population, I think it's probably going to be not as severe in ways that it was in the first one, because the public is more aware of it and we're taking more of the precautions. The herd immunity thing, I think again that the understanding of herd immunity is extremely simplistic at the moment, because we can tinker with so many aspects of it now because of epidemiology. So I agree with Michael that we should probably be paying more attention to some of this. But I'm cautiously optimistic. I think the part that worries me is that I think our health professionals have borne the brunt of the first wave, and I don't think much has been done across the world to try and make it easier for them when the second wave comes. And I think that's again something that people are probably not so. We forget that when we lose health professionals, either through morbidity, mortality, or burnout, or the psychological trauma that they have to deal with, we can't easily replace those resources in the time that we need them again.
Yeah, for me, the big question is the first wave over? And what is a wave? I mean, I'm not sure where the terminology from the wave about the wave comes from. Actually, maybe Michael can elaborate, but I don't know where it comes from. It seems persuasive, but it also seems to come from the 1918 to 1920 experience. And if that experience is indeed a case where the epidemic was left more or less unchecked and run its course, then we're in a totally different ballgame right now. And I'm not sure it's actually that helpful to talk about the first and the second wave. For Switzerland, it's clear that the lockdown was successful in the sense that it controlled the transmission rates, it controlled the hospital admissions, and so on and so forth. As soon as the lockdown was lifted, the rates started to rise, first very slowly and barely noticed, but in recent weeks quite quickly and in a politically sensitive way. So I think if we're talking about waves, we're still in the first wave. The first wave hasn't finished, the first wave isn't over, and the first wave will go on into the autumn. And that will differentiate the experience of COVID from the 1918 pandemic dramatically, because we're not allowed to think of it as seasonal, as the 1918 pandemic was seasonal in the sense of having a season in the spring, then something of a mull over the summer, and another season in the autumn. And I don't think we're seeing that. We're seeing the effects of government-initiated lockdowns, yes, but we're not seeing much of a change in the virus and its behavior, if a virus has behavior, unless you count the changes in the age structure relevant, which they well may be. Now, to the question, the central question is, we as historians, what do we predict? And I think we are well advised not to predict too much, because history is about history rather than about the future. That's an unsatisfactory answer, but it's still, I think it's relevant. I think what we have to learn, and what we probably, all of us 6 or 5 here have learned, is the limitations of our own profession. And I think one important discussion to be had is, where are the limitations of the various sciences involved in the debates about COVID? And I think if the sciences, the medical profession, the historians, whoever, is more proactively delineating strengths and weaknesses of their own field, then I think the conversation between the various sciences can be more productive. And I finish this by saying, I find it very noteworthy that, at least to my knowledge, no country has included historians in their expert advisory groups. I think that's an important area. I think we should be on the expert advisory groups, not because we predict the future, but because history is of such paramount importance for all the modeling, for all the scenarios, for all the planning in relation to the future. So I think expert advice in history is much required.
Canada actually included an historian of the 1918 pandemic on one of its scientific advisory boards from the University of Manitoba. So Trudeau has some sort of foresight around expertise, I guess.
And I think I'll take on Flurin's challenge and try to make history predict, and with all its problems. And this is, and I'm using history to. So we are talking about in terms of waves of COVID. We are talking about the future history of COVID, and nobody knows. But the only way I can think about it is from an historical example, and I'll give you the example of cholera, which had 6 pandemic waves throughout the 19th century. And what patterns do you see? And don't worry, I'm not going into the details of each wave, but the patterns you see is, by the 3rd wave, which kind of ended around the 1850s, it had become a global pandemic. Every corner of every major continent except Antarctica had cholera. And you also see, by that time, the beginning of the preventative measures. So by the 4th wave, which was in 1860s, you see a geographical contraction of the pandemics into the parts that had not taken the preventative measures. So by the 5th and the 6th wave, you have a different geographical pattern in Asia, in parts of Africa, in Russia, that the pandemic wave was taking place, which in a way suggests that the COVID-19 future depends on what different nations, what kind of preventative and public health measures different nations will take that might shape the pandemic in that direction of what countries will be more affected and how. So that is a projection that it will not be in the same shape, and cholera was not in the same shape. It was absolutely reflective of the different countries' preventative measures that they took. The other is a class pattern that Samiksha reflected. Increasingly, what you saw in cholera is that it's the poorer sections that were increasingly repetitively affected by, as the wealthier section had more protected water supply and the separation from sewage to drinking water systems. It became a much more class disease. And COVID might become, as social distancing is an economic privilege, and more working class people will not be able to have social distancing. So you might see a geographical pattern which will give you the preventative health map of COVID. You will also have a class divide, which will give you the economic divide of that society. So future COVID-19, and that's my prediction, and don't hold me to that, will reflect a kind of geographical pattern and also class pattern.
Thank you for that. It's obviously a worrying thought, and I think it leads me to another question, which is about the vaccine, whether there will be one and who will have access to it, and what we can learn from historical examples of that. And I know Michael's been thinking about 1957 and the vaccine.
I mean, in thinking about the vaccine, or a COVID vaccine, again, I mean, there's the sort of the whole bit of the historical contingency. I mean, what I find striking is what sort of examples do we have? What examples do we have of efforts to develop and then distribute a vaccine in the midst of a pandemic? I mean, the 20th century is, you know, as some historians have pointed out, really is the kind of the age of vaccinology. I mean, it's not the 19th century so much as the 20th century, and you know, remarkable developments in mass vaccination. And you know, there's the getting back to Flurin's point about you know, the sort of the medical progress model. I mean, there's the great example of smallpox eradication. So there are really good examples of the very effective development of vaccines. I mean, there's different questions around uptake, and there's different questions about access. But I think the big question, at least for one big question for historians, is what kind of examples exist of efforts to produce a vaccine in the midst of a pandemic. And I think there aren't very many examples. I mean, that's why I've been interested in 57. Other historians have as well, and also again in the 68 flu pandemic. I mean, this 57 is called the Asian flu, so there's a sort of a geographical aspect to this. And what's really evident, or one thing that is very evident in 57, is that most governments, European, but also, you know, World Health Organization and non-European governments, take very little in the way of social distancing, social isolation measures. Very little in the way of what we sort of like allude to as quarantine. There was a kind of a push towards using the 57 pandemic as a way to test the capacity, the ability to produce a vaccine in the midst of the pandemic. And I think one lesson that comes out of that pandemic is they failed. There was, the capacities were not there. The scale of production was not there, whether it be in the United States, whether it be in Britain, whether it be in France or elsewhere. And was an even bigger problem that arose, and this gets back to something that Pratik, I think, and also I think Flurin, this idea of nationalism. There was in 57 and again in 68 a kind of vaccine nationalism, whether it be private companies, pharmaceuticals producing for first world American or British populations, or governments, the Russians, for instance, developing their own vaccines. There is very little in the way of thinking about sharing, exchange, equity in the production of vaccines at this time. So there's a capacity problem. Can you produce enough vaccine in enough time to prevent influenza, which is rapidly spreading, No, in 57. And again, 68, there's a little bit more lead time, but there is, but by and large, very few people get the vaccine at a population level, and the effectiveness of the vaccine is rather mixed. And then there's also the bigger question of access. And this lingers right through up to the worries about avian flu in the 90s and the early 2000s, and then of course swine flu, where issues of access in the midst of a pandemic was a huge issue, particularly for places like Southeast Asia, like Indonesia, which was readily supplying the World Health Organization and Australian and other pharmaceutical manufacturers with vaccine samples, but not getting access to the vaccines or virus samples rather, but not getting access to the vaccines themselves. So I think in each case, the 57, 68, and 2009, there are big questions around not just capacity and production, but also around equity. And one thing that I guess the problem of producing a vaccine in the midst of the pandemic is about, well, who gets access to it? Who gets prioritized? Not just at the national level, but at the global level. Even if a vaccine is produced and gets out into the public domain, will it be the preventative panacea that some are suggesting? I mean, I suspect, again, not forecasting and not being predictive as a historian, but it depends on the nature of the virus. It depends on uptake. It depends on a whole slew of different factors. But in terms of living with COVID, I don't think the vaccine is going to solve the problem of living with COVID.
Thank you. And there are lots of factors involved in that, aren't there? I mean, your work with human and animal health and the ability of the virus to mutate, as well as people's resistance to having that vaccine, are obviously perhaps topics that we can discuss. And
sorry, and of course, there's an animal reservoir with flu, and there's an animal reservoir with COVID. So that's the ecology of the virus itself, which is very different from, say, smallpox, is a huge issue. Yes.
I really agree with what Michael is saying about equity and availability. And I think, again, in India, you don't have a very good infrastructure in terms of the number of beds, hospital beds per population, or number of medical practitioners per population, or even just the location of where these things are and whether they are actually functioning the way that they should be. But you do have the ability to produce vaccines on a very large scale. So there are also issues about how these pharmaceuticals or how these drugs get circulated in the non-Western parts, the less developed or the underdeveloped parts of the world. And India has played a role in terms of manufacturing these drugs for countries which can't afford the more expensive drugs produced in places like North America and elsewhere. So there is, again, where capacity exists, and of course there will be attempts at prioritizing national populations instead of international cooperation. I've been heartened a little bit by seeing how there has been much more international cooperation in terms of developing the vaccine and exchanging information about it, and even getting ready for producing it in sufficiently significant numbers. But I think Michael is absolutely right to highlight this point, that if we want to solve the problem of COVID-19, I mean, not in the sense that we just completely eliminate it like polio or smallpox or plague, or at least try to contain it in that sense. I think we really need to think of trying to prevent situations that the COVID-19 pandemic has caused. And if we want to do that, then we have to address questions of ecology. We have to address our relationship in terms of animal and human health. We need to radically reconceive these things, and we need to stop thinking at national levels, because we are living in a very global world where travel is a lot easier. The only reason why 1918-19 happened at the scale at which it happened was because it was very closely linked with the movement of people around the First World War. So this sort of new stage that we are in, where we have extremely fast mobility internationally, means that we cannot think nationally about these issues. And we really do need to make a shift in that sense. If we fail to do that, then we can't. We may be able to learn to live with COVID-19, but we will have something like COVID-19 happening sooner or later.
I mean, that's already clear that exactly that is going to happen. I mean, yes, we can hope for international cooperation and all the rest of it, and maybe there are signs that there is a little bit more cooperation than 10 or 20 years ago. But by and large, I think the world as it stands today isn't very strong in terms of cooperation. I mean, look at the debates around the WHO. A largely effective organization with its own problems and its own political history and its own complex track record gets under fire from a variety of groups and nations in the world, and you think, oh boy, how can you undermine the WHO during a pandemic? I mean, that's probably the worst possible time you can do something like that, but it hasn't kept the United States back or anybody else who was or has been criticizing the WHO. I think as far as vaccinations are concerned, one is to go back to our start. The start was that pandemics are political, social and medical events, and vaccinations are of course very political too. And I think when we start dealing vaccination history as a form of political history rather than a success story for medical innovation, then I think we can get somewhere. And I think that was quite revealing what Michael was saying about the various flu vaccination campaigns in 57 and 68. What they teach us is that vaccination in relation to flu basically has failed during the 20th century, but it was successful controlling seasonal, in other words, local flu outbreaks. And that might be a guidance. If COVID turns out to be a regular guest at our tables, as it were, then maybe vaccination policy has a role to play in limiting the impact that COVID has. In other words, it's a tool that allows us to live better with COVID. If COVID turns out to be a big pandemic that strikes in waves similar to the 1918 pandemic, then in all likelihood, vaccination is probably going to be of less importance. So we're at the crossroads in how we deal with COVID. If we're looking for long-term solutions to live with it, similar to AIDS, then vaccination will have a role to play. If we're looking at damage control during a global pandemic of acute importance, then maybe we have to be a little bit more skeptical about the potential for vaccination.
Thank you for those thoughts. I just wondered if we could come lastly back to the differences internationally in terms of inequalities of recording morbidity and mortality and further access to hospital beds and treatment, and what we can think about from past pandemics in those cases, and particularly Pratik and Samiksha, I'm interested in your thoughts.
So we should not think of healthcare in terms of hospitals as this panacea that solves problem, or healthcare or medical care providing the solution to our problems, but not having a certain level of health infrastructure, certain capacity for hospital beds is so not having basic healthcare available to people, which will involve having some hospitals and some dispensaries, some primary healthcare centers. Not having that is a major deficit when we're dealing with epidemics like this. So in the current context, what we've seen is countries like India, which have done very well in terms of keeping up with the latest scientific discoveries, in terms of producing doctors who often migrate internationally and do very well abroad, haven't actually done very well in terms of being able to provide for the needs of their populations because they don't have the basic infrastructure in place. And so one of the things that I learned from this is that in places, and I'll speak specifically of South Asia, in healthcare has never become a political demand in the way that it is in places like Britain or elsewhere where the state provides healthcare, basic public health and healthcare to people. And that is a problem. We need to change that going forward. In India, people will see education as something that the state should provide or should make more of an effort to facilitate, but they do not think of healthcare as something that the state should be responsible for, or that it should make an effort to improve its record on. And this has been pointed out by people as a serious problem with the development model. So we need to stop thinking of development as economic development, the way that it's being done in places like India, where GDP growth is the only thing that people pay attention to. And it makes it very easy for people to not think of investment in healthcare as an important thing that the state should be doing when it is doing well as a form of development. So I think the same issues can be held as true. So the model that the IMF and the World Bank have promoted, which are focused on restructuring of government infrastructure, so that the government reduces its emphasis on providing basic medical infrastructure and basic educational infrastructure to its population, and focuses much more on privatization. We know that private healthcare can never do the same thing that the state healthcare does. And a big spotlight has been shown on the gaps in this thinking in the current pandemic. We do need to change this. So this is more specific to the country that I work on, India. But I think if we think of the models of development that we use internationally, and the way that we think of development and the way that we think of healthcare has to change. Because a lot of people are thinking, how did we get here and how can we prevent ourselves from being here? And often, very irrational explanations are being given to how this will go away. Or an attempt to excessively rely, as Pratik said earlier, on authoritarian governments or stronger states. In the sense that there'll be a strong man who will come and do things, who will take charge and who will fix things for you. And I think this might actually be a moment to open up these questions and to discuss even more vociferously publicly that the ecology of it, the international nature of it, the fact that providing healthcare to some regions is not going to be sufficient in this globalized world. I think this is a moment where we can actually try and at least narrow the gap a little bit, if we can't completely close it in terms of the public's understanding of it and our understanding of it.
I'll make a very quick point, taking Samiksha's point about India and making it a more universal point. I was saying that in India's case, it has exposed the fault lines and in fact the craters of Indian public health facilities, which has it literally has shown that people have absolutely no basic healthcare facilities available to them. But in terms of global public health facilities or debates, it has brought into question the debates around what is known as the fifth wave of public health. And the fifth wave was increasingly going into a direction where the withdrawal of the state. And I connect with Florin's point about the forgetting that and the withdrawal of the state and the public health is more an ownership of the people, its lifestyle, its people's ownership rather than the state's responsibility. And it comes from Florin's point about forgetting of what it did, what it needed from the early 20th century public health investments by the state to bring us to here. And that's that amnesia that almost makes you think that you can have a public health by the public. And COVID-19 has kind of exposed the fallacies of the current debates of the fifth wave of public health, that it still needs a strong, our public health facilities still need, whether it's in India or in Europe or in the US, another example of the failures of the state in providing public health facilities. It reignites those debates about the global structures of public health necessary in this century. So it has kind of exposed the fault lines of our debates about public health.
I completely agree with that observation. I mean, it makes complete sense to me. And now, but then I think there might be another side, which I've been, and I think a lot of people have been struck by, that in the absence of public health infrastructures and systems, or in this shift towards sort of more personalized, personal responsibility, or that the kind of neoliberal model of public health that you're referring to, Pratik. There's what I think the COVID's exposed the fault lines and in a way the failures of that. At the same time, it's also highlighted how people produce different kinds of forms of mutual aid and social solidarity in the absence of. So what do people do? What do communities and even societies do in the absence of those kinds of healthcare infrastructures? They don't just roll over and die. One of the striking features, I think, of COVID is how at local, but even national and then even international level, how the levels of social solidarity, of cooperation, of collaboration. So, I mean, to put the other side of the story is how people have come together, not formally through state structures or international structures, but informally. at community levels, whether knocking on a person's door, getting food for somebody, or in a sort of more sort of anarchistic way, creating the like sort of, forms of, 19th century mutual aid, which is, like not against the state, but you know what I mean. I think that's really, it's a feature of the pandemic that I actually think has probably historical resonances with past pandemics, where people in the absence of the state, whether local, national, or international, have actually done something in response to a crisis. And I think that's a fascinating feature. And I think, and it's a point, I don't know, this comes partly out of having read Samuel Cohn's mammoth book on epidemics. And one of his observations is that in 1918, 1919, there wasn't the kind of violence, hatred, and breakdown of social order that one might have seen in, say, around cholera or around plague. There was a coming together of people, and it got me thinking, actually, this is a feature of this pandemic that we shouldn't lose sight of. Despite what we see in aspects of America or elsewhere in the world where, hatred and division is being propagated and fault lines are being highlighted, there's also a remarkable coming together. And I think as an historian, I'm interested in that aspect of, I wouldn't say human nature, but how people come together, how new forms of solidarity are being produced or drawn upon from, sort of previous experiences. I mean, I think in parts of sub-Saharan Africa, where, longstanding experiences with Ebola and other types of infectious diseases, I think people are drawing upon those resources in the absence of, systematic healthcare infrastructures to actually develop very interesting and novel responses at the local level. And I think this is across the board. I mean, you can see it in Italy, you can see it in parts of even Britain, where the state is kind of sort of evacuated the public sphere in some ways. So I think highlighting cooperation is as important as highlighting the fault lines. That's all I take the point, absolutely, there's fault lines at play here, but there's also remarkable forms of cooperation.
And that connects to your earlier point about living with pandemics. So this is what you described, in a way, is living with pandemics.
And I think in terms of that kind of social disruption and protest as well, with the Black Lives Matter movement coinciding with this, then we can see that solidarity as well as protest all coming together with this pandemic.
I want to take the point about neoliberalism again, because again, I think this has been something that's been one of the things I hope that the case for neoliberalism will have been significantly weakened. The public acceptability of neoliberalism will have been significantly weakened as a result of the public experience of this pandemic. The idea that individual responsibility or private organizations, for-profit initiatives for things like public health and education will do what collective state action should actually do. I hope that fallacy has been exposed, but I think it's been one of the things that has made the global inequities much worse, because this model of for-profit being somehow something that prioritizes patients and is somehow creates more accountability and creates more transparency and improves the efficacy of medical care has been soundly debunked in the experience of dealing with COVID-19, where private healthcare providers, whether it be UK or India, have absolutely failed to do what they were supposed to do, have done it poorly, much worse than what state organizations or local organizations would have done. So I think, and of course, the arguments about rethinking development in non-neoliberal formats have been there since the 1990s and 80s, perhaps, when the push for pushing this neoliberal model across the world, especially in places where there weren't significant infrastructure, to gut the infrastructure even further, have been decimating whatever capacity there had been for communities to draw on. I would also slightly dampen the optimism that Michael is trying to speak to. I do think that solidarity is something that we should be highlighting, and because that is the only way that we can overcome the challenges that we're facing. We also need to acknowledge the role of communities, but we should not be turning a blind eye to the fact that many authoritarian states, many right-wing states are actually using the pandemic as an opportunity to suppress dissent, to actually politically target groups who are pointing out their hypocrisy, pointing out the damage that they're doing to organization, to society. They're taking advantage of the distraction of the public and the lack of transparency and the greater role of the state to actually suppress dissent. And by suppress, I mean sometimes in very, very brutal ways. So yes, we do need, the only way we will overcome this is through solidarity and through strengthening communities. Also, again, communities can be extremely parochial, can often can encourage tribalism in ways that is very unhelpful. So I think maybe if I was to probably strengthen the point that Michael was saying, I think international solidarity, and solidarity which includes people who are less privileged than some of us, who have less entitlements than us. I think that there are plenty of examples of that, and that it is heartening to see that we still have that going despite the many attacks on that.
First of all, just very briefly, I'm not sure that the neoliberal model has been rejected. I live in a country with a very liberal healthcare system, and it's doing very well. I think what is now required is an exact analysis what has happened in the various models in the various countries, and how has the decision making that was chosen affected the outcomes that the various countries have reached. But I wanted to make a different point. In the briefest possible format, I would say that the 20th century is also the century of structural underfunding of public health. That's what you're getting a public health crisis when you insist for 50 or 70 years to redirect funding that used to go into public health and redirect it elsewhere. So I think that point needs to be made in the sharpest possible format. But also I'd like to draw emphasis again to the historicity of public health. And I think what I observe here in Switzerland is that even public health experts in 2020 have forgotten the lessons of the AIDS pandemic, or have forgotten the lessons of the 1980s and 1990s of the AIDS pandemic. And those lessons were involve the activists, involve the groups you want to reach in the policy making as you go along in order to upgrade the uptake that the policies later on have. And I think in COVID, we see, at least in Europe, in a European perspective, we clearly see the nation state doing whatever it thinks is best, more or less without listening to the population, more or less without listening to the target group that they actually want to reach. And I think here's an easy lesson for public health in the second, third, or the fifth, or the 10th wave of COVID-19. Start to bloody take the population along. And I don't think the authorities have done a very good job in that. And I think that's an easy lesson to take. It doesn't cost very much to involve, let's say, a couple of long COVID sufferers in the policy making, in the communication strategies, and actually listen to them, listen to their stories, listen to how it feels when you suffer from COVID for 3 months, rather than emphasize, oh, we only had 1 death today, so it's actually not very difficult to deal with. The healthcare system is doing very well. I think the public health system needs to build a historical reflection into everything it does, and it needs to learn from the historical reflection that it pays to have the activists, to have the population along for the ride.
In terms of thinking about what historians can offer to that, then polio epidemics as well, I think, can really help to understand that for states and those long-term legacies that can come from disease outbreaks, amongst many other diseases which have long-term consequences. So thank you so much to Pratik, Michael, Flurin and Samiksha for joining us today. And I think that there are a lot of topics that have come up in terms of the areas we've discussed that we'll hopefully tackle as well in future webinars, such as not just the long-term consequences for people who suffered from coronavirus, but also in terms of lockdowns and quarantine, the mental health aspects of coping with epidemics. So how do we live well mentally as well as physically? And that's a topic I hope we'll take up in future. So thank you very much again, and we'll be following this up with future webinars.